Iron deficiency anemia. Definition of anemia. It is defined as decreased concentration of hemoglobin and red cell mass compared with that in age-matched controls. So, to have an idea about this, we should know the normal value for different age groups. The highest level of hemoglobin and hematocrit is usually found in the cord blood. As you can see, it is 16.8 with a range of 13.7 to 20 and a hematocrit of 55 with a range of 45 to 65. Then it will decrease starting by 2 weeks until we reach the age of 3 months where the hemoglobin is 12 and this is called physiological anemia of infancy. Up to the age of 6 months to 6 years, it is 12, and then by 7 to 12 years, the hemoglobin is 13 and the hematocrit is 38. What happens when there is anemia? It means physiology of anemia. There will be tachycardia, increase in the cardiac output, and shift of the oxygen dissociation curve to the right, as well as increase in the 2,3-diphosphoglyceride within the red cell till the hemoglobin fall to a level of 7 to 8 gram per deciliter, where pallor become apparent in the skin and the mucous membrane. Anemia can be classified according to the mean corpuscular volume. It means morphologically into 3 groups. When the MCV is less than 75 femtoliter, it is microcytic anemia. It means the MCV is low. When the MCV is normal, 75 to 90 femtoliter, it is normocytic anemia. And a high MCV, more than 90, will end with macrocytic anemia. Another classification is the physiological classification. We have 2 groups, either anemia caused by decrease in the hemoglobin or red cell formation, or due to increased red cell destruction or loss. It means hemolysis. What about the general clinical manifestation of anemia? It is very important to discover anemia while the patient is asymptomatic, and this is usually done during screening. Once the patient is symptomatic, we have 2 groups, either stable or critically ill. The stable one, the patient will have pallor in the skin and the mucous membrane, easy fatigability, and poor concentration, while critically ill have severe pallor, congestive heart failure, and irritability or drowsiness. This picture shows the iron in hemoglobin and hemoglobin structure. Usually in the red cell we have 4 hemoglobin chain, 2 alpha and 2 beta. We have heme group, and iron binds to 4 units of oxygen. What about iron absorption? The main site for absorption is the duodenum, where most of the drugs are absorbed, as well as from the upper jejunum. Vitamin C taken with the iron will increase its absorption by reducing dietary ferric to ferrous iron, while caffeine and other xanthine group decrease its absorption. Iron deficiency is the most common cause of anemia worldwide. Globally, it is estimated to be 30 to 50% of the global population. And most of these individuals live in developing countries. It is the commonest type of hypochromic microcytic anemia. To understand the process, a full-term newborn baby or infant contain about 0.5 gram of iron, while the adult contain 5 grams of iron. This change in the quality from birth to adulthood means that an average of 0.8 milligram of iron must be absorbed each day during the first 15 years of life. Small additional amount is necessary to balance normal losses of iron by shedding of the cells. It is therefore necessary to absorb approximately 1 milligram daily to maintain positive iron balance in childhood. Because less than 10% of dietary iron is usually absorbed, a dietary intake of 8 to 10 milligram of iron daily is necessary to maintain iron level. During infancy, when the growth is rapid, the 1 milligram of iron per liter in the cow milk and breast milk make it difficult to maintain body iron. Keeping in mind that iron in the breast milk is absorbed 2 to 3 times more efficiently than iron in the cow's milk. Nonetheless, breastfed infants are at risk of developing iron deficiency anemia without regular intake of iron-fortified food by 6 months of age. Now we are going to talk about causes of iron deficiency. The most important and the commonest cause is inadequate dietary intake of iron, and this is especially seen in infants in the postnatal period, as neither breast milk nor cow milk contain adequate amount of iron. In addition, high carbohydrate diet, excessive milk intake more than 24 ounces per day. Usually, the onset of this iron deficiency anemia starts by 9 to 24 months of age and being earlier in a preterm baby because the stores of the preterm baby is much less than that of the full-term babies. The second cause is increased physiological requirement, and this is seen in infancy during rapid growth and can be aggravated by prematurity, infection, and delayed mixed feeding. Another period of rapid growth is that of adolescent in both sex, plus menstrual loss in female, intense exercise conditioning as in competitive athletes in high school. The third cause is chronic blood loss, and this is usually seen in older children who are older than 2 years of age. The loss may be from the GI tract due to the following causes: milk protein inflammatory colitis, hookworm infestation, H. pylori infection, aspirin ingestion, presence of hiatus hernia, Meckel's diverticulum, polyps or hemangioma, presence of ulcerative colitis, and chronic diarrhea. The second system for loss is the urinary tract, as in chronic or recurrent hematuria in hemophiliac patient. It may be from the skin, as in those with eczema, and it may be caused by massive blood loss anywhere in hemophiliacs, for example. The fourth cause is malabsorption syndromes, mainly celiac disease, cystic fibrosis, and fever for any reason. Now we are going to talk about the clinical feature. Most children with iron deficiency anemia are asymptomatic and are identified by routine screening test done by 9 to 12 months of age by doing the RDW, which is the red cell distribution width. Normal hemoglobin values vary according to the age, gender, race, and method of testing, whether it is capillary or venous. The most important recognized clinical sign is that of pallor, but is not usually visible until the hemoglobin reaches to a level of 7 to 8 grams per deciliter. Mainly, pallor is noticed in the palm, palmar creases, nail beds, and conjunctiva, and usually parents often fail to note that their child is pale because they are living with him all the time, but it can be detected either by visiting friends, relatives, or doctors. Older children may report cold intolerance, fatigue, exercise-induced dyspnea, or decreased mental acuity. In mild to moderate iron deficiency anemia, when the hemoglobin is 6 to 10 grams per deciliter, compensatory mechanisms occur, including increased level of 2,3-diphosphoglycerate and shift of the oxygen dissociation curve to the right, may be so effective that few symptoms of anemia will be noticed apart from mild irritability. Once the hemoglobin becomes less than 5 grams per deciliter, irritability, anorexia, and lethargy will be more, plus a systolic flu murmur can be heard, and if the hemoglobin continues to fall, there will be tachycardia and high output cardiac failure. Iron deficiency may have non-hematological systemic manifestation because both iron deficiency and iron deficiency anemia are associated with impaired neurocognitive function in infancy. And iron deficiency anemia also associated with irreversible cognitive defect later on. Some studies suggest that there is an increased risk of seizure, strokes, and breath-holding attack in children with iron deficiency anemia, and exacerbation of restless leg syndrome in adults. Both iron deficiency and iron deficiency anemia have the potential for adverse neurodevelopmental outcome. Other non-hematological consequences of iron deficiency include pique, which is the desire to ingest non-nutritive substance, and pacophagia, which is the desire to ingest ice. Pique ingestion can result in ingestion of lead-containing substance, and the outcome is concomitant lead poisoning, which is known as plumbism. In school-age children, there is impaired learning ability and poor school performance. Also, there is increased susceptibility to infection because of impaired cell-mediated immunity and decreased bactericidal effect of phagocytosis. Now we are going to talk about the investigation. Of course, the hemoglobin is low, below the accepted for age, as well as there will be decreased hematocrit, MCV, MCH, and MCHC, with increase in the RDW. Normally it is 10 to 14%, and this is very important to differentiate from thalassemia, which is manifested at the same age group, but the RDW will be normal. In addition, there is reduction in the red cell count, and the blood smear reveal hypochromia and microcytosis when the hemoglobin is less than 10 grams per deciliter. The reticulocyte count relatively low or normal, and platelet count high or low. The serum iron is low and the iron binding capacity is high, with a low ferritin less than 12 nanogram per ml, while the transferrin saturation reduced to less than 10% and free iron erythrocyte protoporphyrin is elevated. One should look for presence of occult blood in stool and should check for lead level. It was found that therapeutic trial of iron caused reticulocytosis, which peak between 5 and 7 days. Bone marrow examination revealed no iron stain. An increase in the hemoglobin more than 1 gram per deciliter after 1 month of iron therapy is usually the most practical means to establish the diagnosis. This slide shows a normal blood film. You can see normal RBCs, few platelet, and this is a lymphocyte. If a patient is having iron deficiency anemia, the red cell become smaller than normal and have an increase in the central zone of pallor. This indicative of hypochromia. It means less hemoglobin in the red cell, and there will be microcytosis, which is small size of the red cell. Also, there is anisocytosis. It means variation in shape, and in size, and poikilocytosis, which is variation in shape. And as you can see in this slide, the number of the platelet count is increased. It means there is thrombocytosis. There is also rouleau formation, and there is pencil-shaped red cell. This slide is a bone marrow stained for iron using Persian blue stain. The blue discoloration on the left indicate iron presence in the bone marrow, while on the right you can see no iron stain in the bone marrow. It means severe iron deficiency anemia. Iron deficiency anemia should be differentiated from other causes of microcytic hypochromic anemia, thalassemia syndrome, lead poisoning, sideroblastic anemia, and anemia of chronic infection. Treatment. First of all, very important to have a nutritional counseling to the family. You should advise the mother to maintain breastfeeding for at least 6 months of life and use iron fortified infant formula. Restrict milk intake to 1 pint per day، يعني يشربوا glass الصبح glass بالليل. Supply iron to low birth weight baby and preterm baby as early as 2 months of life, and full-term baby as early as 4 months of life in a dose of 2 mg per kg per day, which is preventive dose. Facilitate iron absorption by taking vitamin C rich food such as citrus fruit, tomato, and potatoes. Give meat, fish, and chicken, which are iron-rich diet, and avoid tea, phosphate, and phytate as they prevent iron absorption. What is phytate? To have an idea about phytate-containing diet, phosphorus is stored in a plant-based food as phytic acid. When phytic acid binds to other minerals such as manganese, zinc, or iron, the two form a compound known as phytate. The phytate-containing diet including nuts, whole grain, seeds, and beans. After that, we should start iron therapy in a higher dose than the preventive dose, using a dose of 4 to 6 mg per kg per day, mainly ferrous sulfate, which is containing 20% of elemental iron, up to 200 mg per day maximum. If ferrous sulfate not available, we can use ferrous gluconate. Iron should be given between meal with vitamin C containing juice. And check reticulocyte count 1 week later and the hemoglobin 2 to 3 weeks later, where the level should reach midway level. 2 months usually need to achieve normal hemoglobin, and another 2 months of therapy for replacement of the stores. After that, we should reduce the dose to 2 mg per kg per day for another 2 months as a maintenance dose. Injectable iron, whether IV or IM, are available but should be avoided only in the presence of malabsorption or poor compliance. It can be given. Only low molecular weight iron dextran is US Food and Drug Administration approved for the use in children with iron deficiency. A blood transfusion is indicated when the hemoglobin is less than 4 grams per deciliter. It means we have severe anemia, in the presence also of infection and debilitation. What happens when you supply the child with iron? Within 12 to 24 hours, there will be a replacement of the intracellular enzyme, subjective improvement, decreased irritability, and increased appetite. Within 36 to 48 hours, there is initial bone marrow response, erythroid hyperplasia. Within 48 to 72 hours, there will be reticulocytosis, and within 4 to 30 days, there is increase in the hemoglobin level by 0.5 gram per deciliter per day. And within 1 to 3 months, there will be a replacement of the stores. Sometimes we give iron to the child, but we notice that there is failure of therapy. This may be due either to poor compliance, it means the child is not taking the medication, poor absorption, it means there is malabsorption syndrome, persistent unrecognized blood loss anywhere, coexistent disease as hepatic and renal failure, infection and malignancy, concomitant B12 or B folate deficiency, and inadequate dose of iron, the use of certain medications that interfere with iron absorption, including antacids, proton pump inhibitors, histamine 2 blocking agents, bran, tannins, and phytate, associated lead or aluminum toxicity, wrong diagnosis such as thalassemia, hemoglobin C and E disorder, anemia of chronic disease, sickle thalassemia, hemoglobin SC disease, lead poisoning, and iron refractory iron deficiency anemia, and other rare microcytic